I'm Dr. Dorothy O'Keefe. I'm a child and adolescent psychiatrist at the Virginia Treatment Center for Children, which is part of the Virginia Commonwealth University School of Medicine. I do mostly outpatient work, which is why I'm very interested in this coding, these new coding developments. And this is the AACAP's CPT Coding and Reimbursement Committee who are presenting the forum today. We have the top list of participants are the people that are present, and they're going to introduce themselves in a second. Additional members listed at the bottom are not present today. Want to introduce yourselves, guys?
Yes, I'll start. I'm Benjamin Shane. I'm the AACAP CPT advisor to the AMA, as well as the co-chair of the AACAP CPT Coding and Reimbursement Committee.
I'm Sherry Barron Seabrook. I'm the AACAP RUC advisor, and I'm also co-chair of the Coding and Reimbursement Committee.
I'm Dr. Jason Chang. I'm a child psychiatrist in the Chicago area. I'm the CPT alternate advisor.
And I'm Morgan Fowler. I'm a first-year child fellow at University of Chicago, and I'm one of the members of the committee as well.
Hi, everyone. I'm Karen Ferguson. I am the Deputy Director of Clinical Practice at AACAP, and I serve as the staff liaison to this committee. Welcome.
Okay, just a quick review of the logistics. You all are muted during the presentation, during the forum, but feel free to type questions into the chat. We've got folks monitoring that. We'll be starting with a brief presentation. That's an overview of some of the CPT coding guidelines, and then move into the balance of the time, which will be answering your questions. We have some questions that have been submitted in advance. We'll start with those and then take the questions as they come into the chat. If we are not able to get to everyone's questions today, they can be submitted to Karen Ferguson. Our formal end time is 1:30 Eastern time, but the discussants will stick around for a bit longer than that, maybe till around 2 o'clock if we need to answer further questions. And the forum is being videotaped, so you can go back and watch it later on the AACAP website. Okay, so our objectives today is to give an overview of the new outpatient E&M framework, which has been in place since January of this year, to discuss how to apply the codes to real life situations, to discuss some guidelines for documentation for your outpatient visits, and then of course, to answer the questions that you all may have. So the codes that were updated in January of 2021 are the office and outpatient evaluation and management codes that deal with new patients and that deal with established patients. There's also a new prolonged service code identified, and we'll talk about that in a little bit. I want to remind you that all the other E&M codes, that is inpatient codes, nursing care facilities, consultation codes, none of those have changed. So the criteria we're talking about today apply to outpatient codes. And if you do work elsewhere in other settings, what we're talking about today does not apply to coding for inpatient and other services. So just to start off, again, and this should be reviewed because you all have been doing this since January, to select the evaluation and management code level, you've got two options. One option is to code by medical decision-making, and the other is to code by total time. There are some changes in both of those, and we'll talk about them. It's important that you know how to do both, because even though coding by medical decision-making is most often the most efficient way to code, there are certainly certain situations in which you will benefit by coding your visit by the time that you've used. It's entirely your choice with one important exception. When you're using a psychotherapy add-on code, you must code your E&M portion of the visit by medical decision-making. You may not code by time and add psychotherapy. So medical decision-making, defined by 3 elements. These are the same 3 elements that we've had in the past: the number and complexity of problems, the amount and complexity of data to be reviewed, and the risk related to management decisions made at the visit. This is not the risk of the patient's illness, it's the risk of the interventions that you are thinking about or going to implement. It's important to realize that it includes the possible management options that you consider, but may decide against implementing. So for example, if you consider starting medication, but elect not to do so, that's still prescription medication management, as long as you document that that's what you've been thinking about. Now, I'm going to do that obnoxious thing and say, don't worry about all the stuff that's on this slide. I'm just showing it as preliminary to the next slide. But what you can see is across the top, the elements of medical decision-making: problems, data, and risk. And down the side, the level of medical decision-making according to the code that with which it matches. I don't know why my boxes didn't end up in the right spot. I promise I'm a better child psychiatrist than a slide maker. What I want to point out to you on this slide is that big column in the middle about data. There's a lot of stuff in there, but for child and adolescent psychiatrists, most of the visits that we do, the elements that are going to determine our code or raise it to a higher coding level really don't involve extensive data collection. And so what Ben has done for us, and these this chart and the next one that I'm about to show are available on the AACAP website for you to print and carry around with you if you'd like to. This is the simplified elements of medical decision-making. You'll see the level of medical decision-making on the left, the number and complexity of problems, and the risk of the management options. It has taken out all those data columns. It has taken out a few risk items that we don't particularly deal with. And you needed 2 of the 3 to choose your code. In other words, the highest 2 of the 3. And so on this slide, if you're using 2 elements, problems and risk, you need the 2 of them to reach the level at which the 2 of them are the highest, are the level that covers your medical decision making. I want to point out something in particular here. On the risk column, moderate is prescription drug management. That's where it's always been, and that's what we're used to using. However, under problems, moderate level of problems is easier to achieve than it used to be in the old coding system. So it is likely that more of your visits will end up being 99214 follow-up visits than previous, because specifically, I'll draw your attention here, 2 or more stable chronic illnesses. In the past, if you had a patient with 2 illnesses, but both of them were solidly managed and not getting worse, that did not rise to the level of moderate or 99214. So you may notice, as I certainly have, that fewer visits are 99213s for follow-up and more 99214s. I have, and I would suggest this, copied off this list of things that qualify for moderate problems. I have an auto text in my electronic medical record, and I put that in, and then I take out the ones that don't apply to that visit, so that I'm telling the coders it's moderate because 1 or more chronic illnesses with exacerbation, or 2 or more stable chronic illnesses and prescription drug management, for example. The other way that you can code your visit is using time to select your code. This has changed from how it used to be as well, in that now all of these things are included in time. That is, everything you do with and for that patient on the day of the visit. So you count the time that you spent preparing to see the patient, reviewing any records or tests, the time you spend taking a history and doing your examination with the patient, the time you spend ordering your medications or other interventions, any counseling time, any communication with other healthcare professionals on that day, not necessarily while the patient is present, could be later that day, time you spend documenting, and any independent interpreting of results. I also have an auto text for this. All of these things, put that at the bottom of the note if I'm coding by time. The time for today's code includes the following events. Then I take out the ones that I haven't done, like if I haven't spoken to another healthcare professional about that patient, I just delete that line. The time used is calculated differently than it used to be. What you see here are the minimum times required for each code. Of course, there's a range. So for example, if we look at our established patient codes, 99213 is from 20 minutes to 29 minutes. But really all you have to know is the threshold, which is you spend 20 minutes total, you've accomplished a 99213. Once you've reached 30 minutes, you've accomplished a 99214, and so on. Again, it is harder to get to a 99214 by time than it used to be. So efficiency-wise, it's you code higher by using your medical decision-making criteria. But again, we all have these visits sometimes that end up with lots and lots of discussion over the problem, and then it might be wise to be able to use the time. This chart is also on the Academy website. Questions come up frequently about add-on psychotherapy. The add-on psychotherapy codes have not changed. And so as you know, 90833 is for 30 minutes of psychotherapy when it's performed with an E&M service. 36 is for 45 minutes, 38 is for 60 minutes. The counting the time hasn't changed for psychotherapy, so it's different than it is for E&M. And that is, of course, when you pass the midpoint of the interval. So at 16 minutes for 90833, you've qualified for that code. At 38 minutes, you've qualified for the 90836. Remember, if you're using time for your add-on psychotherapy, you have to use medical decision-making for your E&M service. Prolonged service. So we had a new code developed, 99417. And what I can tell you is that this code has not been given an RVU valuation. So basically, there's no financial value to this code. All of that is, it is, pending reconsideration, so we don't know how it's going to end up. But right now, this code is not being paid for. However, I'll just tell you what it is to be complete. It is used every 15-minute interval above the threshold for the highest level code in that code family. So basically, for 99215, begins at 40 minutes, 15 minutes more than 40 minutes you would if you code the 99417. You can only use it, of course, when you're coding by time, or in theory, you could use it when you're coding by time, and it has to be on that same date. Medicare has a separate code, the G2212, and the reason is because Medicare objected to the fact that you were paying for the extended visit within the time limit for the code. And so that first 14 minutes, they said you were double dipping on the 99215 and the extended time. So the Medicare code begins at the top of the time period. So it's 15 minutes, every 15-minute interval above 74 minutes on a 99205 or above 54 minutes on a 99215. And again, this is only Medicare. Prolonged service codes are really a work in progress. We still have some of the old prolonged service codes or legacy prolonged service codes. 99354 or 55 is the prolonged service with direct patient contact. It can't be used with the E&M codes, but it can be used with other codes, for example, psychotherapy codes. There's limited usefulness to the 99358 and 59, which were prolonged service without direct patient contact, because it can't be used on the same date, can't be matched with an outpatient E&M code. It exists, but it's going to be hard to find a place to use it. And of course, the inpatient prolonged service codes still exist. They have not changed. Finally, to talk quickly about some documentation guidance. One of the ideas behind the new codes was an attempt to decrease the burden of excessive documentation. So if you remember all the bullet points, there were required numbers of things you had to do in the review of systems. There were a required number of items on your mental status exam that you had to remember and include for each level of code. That's not the case any longer. Now, your documentation of your history and your exam, you obviously have to have some documentation, but it is defined by medical necessity, what's medically indicated, so as much or as little as is appropriate to support the service that you're doing. Of course, documentation should always include the date, who's present, the reason for the visit, where your information is coming from, including any new information, test results pertinent to the visit. And then in particular, what you want to include, this is the most important thing, the rationale for your treatment decisions, because that's really what the purpose of the note is. And feel free to include any additional information that that explains difficulties or specific attributes of the service for that particular patient. Documentation tips. Use language that supports the criteria that you've selected. Now, again, on the AACAP website, you will see the chart with all these definitions. These words right here, severe, chronic, systemic, those are not just adjectives the way we know them in the English language. Those are words that have specific meanings for CPT. So if you look them up, use them to describe the service that you're doing or the problem that you're seeing, so that it's very clear that you've coded, that you've justified the code for that particular service. It's important to reference each problem addressed in the visit, either noting that it's stable or citing the intervention you're using. Again, documenting the decision-making at least as thoroughly as you document the data. Make sure to note the interventions that you've considered and not selected. I considered starting this person on antidepressant medication, but we talked about it and decided to give the therapy a trial first. That way, you've done medication management. If you've considered hospitalization, but decided that you can make a safe plan for the person to go home, you document that, and then you've reached the level of the high-risk decision-making. For time-based codes, list all that you've done on that day. Now, one thing that people sometimes question is with new patients, when you can't use E&M codes, the definition of a new patient remains the same. It is a patient that has not been seen by you or anyone in your group of the same subspecialty within the past 3 years. So if a patient was seen by your colleague and then goes away and then comes back 2 years later and they happen to be scheduled with you, that is not a new patient according to E&M. So what do? Well, we still have this code, the 90792, which is a procedure code for psychiatric evaluation with medical services. There's no time requirement. It can be for some payers used twice. So if you see the parents and you see the child separately, you can bill for that psychiatric evaluation. And I'd like to point out something. I get paid in my university. I get paid by work RVUs, and work RVUs for 90792 are 4.16. None of the evaluation and management new patient visits have that many work RVUs. So it's actually financially, for me, and depending on how your system works, might be financially advantageous to bill a 90792. It's the same, I mean, I do the same service. Okay, for more information, go to the AACAP website, www.aacap.org. Under the Member Resources tab, choose CPT and Reimbursement. On that website, you will find the webinar on 2021 outpatient E&M coding. It's a longer, much more extensive explanation of how to use all these codes and what all these words mean. You'll also see a webinar that gives clinical examples, case examples, and how each of those are coded. You'll see the coding criteria charts that I've referred to, and you can print them out. You'll also see a music video written and performed by our own Dr. Shane for your education and entertainment. And also, if you want to look back, you can find the older webinars from the original 2013 transition to E&M coding. So for some background information. And finally, I'll put Karen's email address up here again. That's where you may send your questions if you have additional questions after this webinar is finished, forum is finished. Okay, and now it's time to turn to the questions. So again, we're starting with some previously submitted questions, so we'll go through them and then take questions that come up that you've presented through the chat. Thank you.
Great. Thank you so much, Dr. O'Keefe. That was wonderful, as always. So our first question is for Dr. Shane. The question is, most of my patients either have either 2 stable chronic diagnoses or 1 diagnosis with an acute exacerbation. Is it appropriate to be using mostly 99214 codes?
The answer is it's appropriate to use what you meet criteria for. We treat mostly chronic illnesses and commonly have either 2 of them, 2 or more, or have 1 that has something going on, either symptoms or side effects of treatment. For child psychiatry, 99214 is a common, occasional 99213, occasional 99215.
Okay, great. And as we ask these questions, if anyone has any follow-up questions to some of these answers, feel free to put that in the chat as well. We can always come back to those things. So the next question for Dr. Baron-Seabrook is, if I am seeing a highly complex patient weekly or biweekly, and I am making complex medical decisions and addressing multiple diagnoses, can I continue to code 99214 every week?
Yes, because as long as you document the number of chronic and or ongoing and or acute exacerbations of your patient and document what your treatment plan and your medical reasoning is for that treatment plan, you can code it. So it's all in your documentation of coding what you do.
Perfect. Next question for Dr. Shane is, in the case of an established patient, if the child or the patient is not available during the medication management session for a legitimate reason, will I still be able to code the visit? And when you document, should it be mentioned that the child was not present?
Okay, so let me answer the last part of it first, which is that you should always document who's present, regardless of whether the child's present or whoever's present. That should be in the note every time. As far as if the child is not present, there are 2 types of ways that's true. So, for example, let's say you have a telehealth encounter. The parent, is on the video. The child is hiding under the covers or is on the other side of the door in the bedroom screaming. The child is present in those cases. You simply document the mental status that you have available, but the child is present. Now, if the child is not present, the short answer to that question is that we may code based on time, and unfortunately, this is not specified in E&M criteria. We were unsure, and so submitted that formal question to the AMA staff, who came back with that we can code based on time because time includes counseling with parents. It's still unclear whether you can code based on medical decision making for those appointments. I think probably not, but at least according to the AMA, we can code based on time.
Okay, perfect. Next one is for Dr. Baron-Seabrook. I was going to go Dr. Sherry Baron-Seabrook, give you the full name. Okay, okay. So it's, if I end up seeing the parents only. Wait, is this the same one? Yes, it is. Okay, it's kind of the same, similar theme. This has come up a lot actually about if the parents are only there and the patients aren't. So the question is, if I end up seeing the parents only when the child and adolescent cannot make the appointment, what is the best code to use if I'm doing both therapy work and complex medical decision-making with regards to meds. In the past, I used code 90846, Family Psychotherapy without patient present, but can this be billed along with an E&M code?
No, the family therapy codes cannot be billed with E&M, only the psychotherapy codes. And the psychotherapy codes require that the child be present at least part of the time, perhaps up to 50% of the time. So the only way you can really code that is by using time on the E&M codes. So you would, however much time you're spending 45 minutes of time, you can code a 99215 based on time. Half an hour, you would code a 99214 based on time.
Actually, so I have a different answer to that question. 90846, 90847 may be used with an E&M on the same day if, number one, they are distinct services, and number two, you append a 25 modifier to the E&M code, which indicates that it's used on the same day as a procedure code. So unfortunately, we don't always agree. So, take that into account.
Great. All right. Next one for Dr. Shane is it appropriate to code a 90833 for 16 minutes of psychotherapy along with a 99213 and 99214 EM code in a 30 to 45 minute appointment if that is truly the services that are being provided?
They need to be distinct services. You need to meet medical decision-making criteria for the E&M code and take into account that even though it's not timed, it still takes time to do it. And so you need to keep, and the psychotherapy code needs to be based on the psychotherapy time rather than a mix of the medical decision-making and psychotherapy. But the brief answer is yes.
Okay. And next question I have is there a way to code for things we do that take extensive time, such as collaborating with human service center team members or one-to-one consultations with physicians, providers about patient care on a day we aren't seeing the patient?
If you have seen the patient within the last, I think it's 7 days, week, you can try and use one of the prolonged service codes without patient present. These codes are all under review, and so it's not clear what is going to be reimbursed and what is not going to be reimbursed on these. The other way you can do that is basically that's what you would have to do if it's not on the day of service. If it's on the day of service, it can be part of your E&M time-based code. But again, the prolonged code service for an E&M is also under review, so we can't give you a definite answer about whether you can use the code or be paid for that code. A lot of this applies to Medicare rules. So in some cases, third-party providers will pay for the codes, particularly the 9935859 codes, but Medicare is not really paying for those at this time. Fortunately, that doesn't affect most of our patients.
Yeah. So let me add to that answer. So there are two codes, 99358 and 359. 358 is first hour for long service on a particular day when you haven't seen the patient. 59 is each additional half hour. So those codes actually have not changed. According to CPT, you have been able to use them and you still may use them. According to Medicare, however, those codes require a reference code. So they require that it's a patient whom you're seeing for ongoing services, who you either saw in the past or you plan to see in the future. And so if that reference service is outpatient E&M. Medicare says that they will no longer pay for 358 or 359. Other payers may still pay for it because it's still totally allowed. Now this, Sherry pointed out this is under review. That's true. So we're hoping that there'll be changes to the CPT criteria as in 2023 that will be acceptable to CMS, so that these codes will then be paid by CMS as well.
And the next question for Dr. Shane is, I was previously audited by Blue Cross Blue Shield as I was an outlier in providing a large amount of therapy services for my patients along with pharmacological interventions. Nothing was found in the audit that was inappropriate, but I have to admit concern about a repeat in the future. Is there anything I can do to help prevent this without coding dishonestly?
So the thing, this is actually not a coding question. It's that each insurance company has certain red flags that they use to trigger audits. And this apparently is one of them for the particular insurance company they got audited by. If you're doing the service, you meet medical necessity criteria, you meet CPT criteria, then do it. On the other hand, if you don't want to be an outlier and don't want to get audited again, you may want to change your practice pattern and how you do it.
You may also want to talk to the insurance company to find out why this was being done and explain to them how you work and why you're coding it the way you are, and see what they say in terms of how they want you to document your services. I once had one insurance company that asked for my notes for every session to document that I was actually had this highly complex patient that I was coding as a 99215 at the time. And with the patient's permission, family's permission, I would submit a copy of my notes each time with the claim, and I never had a problem after that. They were always paid.
Okay. And next question is there a code to track time for court appearances? Is it true that there is a code for psychologists but not psychiatrists?
Not that I'm aware of. Not that I'm aware of. I would like to know which code the person says the psychologists are using, and then we can look into it. But I am not aware of any code that specifically says court appearances. There are undesignated services code, both in E&M, which psychologists couldn't be billing, or in the psychiatric services. If maybe they were able to do that and get permission from their insurance company to get reimbursement for that under the I think it's 90899, I believe is the number on that.
Yeah, so I'm going to add to that. So court appearances are two general types. So you're appearing as an expert witness or you're appearing as a witness of fact. If you're appearing as an expert witness, CPT definitely does not cover that service. It's a forensic service that is not a medical service. Witness of fact, maybe, but probably not either. Because it's really not medical service that you're appearing based on something that you witnessed.
Okay. And next question is, and now I'm off I think this may be for Dr. Shane. How do we code for telepsychiatry visits?
So telepsychiatry visits, if it meets telepsychiatry, a telehealth criteria, is considered a face-to-face service. So it's the same code that you would use as if the patient were in your office with a 95 modifier.
All right, and next question. Can we code / bill for phone calls? I think Dr. Baron Seabrook, sorry.
There are codes for telephone phone calls in CPT, so yes, you can code them. The issue is, will you get paid for them? Some third-party people are willing to pay for those, and some are not. So you just have to check with your insurance company. But yes, there is a series of codes for telephone calls in CPT.
And Dr. Shane, do we need to document the start and stop times for a time-based visit? What about an MDM-based visit?
So start and stop times are required by some insurance carriers, particularly some Medicaid carriers. They are not specified for by CPT. So for CPT, you need to document the total time across the day for timed for codes selected based on time, and for codes selected based on medical decision making, no time documentation is necessary.
Okay. And next question is, can you please help clarify how 2 stable chronic illnesses counts for the 3 points that are required for a 99214 visit?
When you look at the first column of nature of problems, it states in the 99214, 2 stable chronic conditions is acceptable. Did I
Yeah.
answer?
So yeah. So let me add to that one. So the thing is, problem points and data points were actually never part of CPT. They weren't even part of CMS, but they were part of common use auditing criteria. So that's that was pretty much how 98% of companies audited, and so that's how we taught it. CPT, as in 2021, has become more specific, and the specificity is on the chart. So 2 stable chronic illnesses is what CPT says is a 99214 for problems.
And the important thing also is you not only list those illnesses that you're treating, but you also document how you approached it during the session. In other words, you can't say, oh, this patient has diabetes and anxiety due to diabetes, but you're only treating the anxiety. You have to treat both conditions or all the conditions you stipulate as being addressed during that service.
Okay. The next question is, can you bill for a 90792 and a 99204 in the same visit?
Not in the same visit.
No.
Bill as your initial session, you could bill it as a 99204 as a new patient. And then if you want a subsequent visit because you are interviewing the parents or second interview with a child, you could do the 90872.
Okay. And then another question is, how do we code for family therapy sessions? Does it change if the patient is or isn't present?
Yes. So there are 2 family therapy codes. 90846 is without patient present, and 90847 is with patient present. And those codes have not changed.
All right. The next one is, a CAP is leaving the practice. Can the new CAP, child and adolescent psychiatrist, do a new 90792 for an established patient of the practice?
It's the same practice, so they can't do code the patient as a new patient this time, because if the patient is a patient of the practice, not of that particular child psychiatrist coming aboard, so it would have to be established patient visit code.
Yeah, so I'm gonna add to that. So that's definitely true for the new patient E&M codes. So you may not bill a 99204, 99205 for a patient who was seen by someone in your practice in the same subspecialty. However, 90792 does not have that restriction. Payers may decide to restrict it, but if you can justify it as a new episode of care because they're changing providers, you can bill a 90792.
And Dr. O'Keefe, did you want to add something? I saw you put your hand up.
That's what I was actually going to say, that there isn't you are allowed to bill a new 90792 if it's a new evaluation to you.
And Okay, and then the next question is, if a patient is transferred from a PHP seen by a child psychiatrist to an outpatient in the same hospital system, can you bill a 90792 for the first evaluation in outpatient?
So yeah, same answer. Yes.
Yeah, based on, our last discussion.
And then next question is, how is insurance tolerance for high frequency billing of 99214?
I don't think we know the answer to that.
Yeah, we would like to have feedback from our members if they're having problems with third-party acceptance of these various situations. But that's not really a coding question. That's an insurance reimbursement issue. We'd be happy to look into that if you provide us the data.
And next question is, our institution does not allow trainees who bill under the supervising attending's name to bill EM on time. How would you recommend we bill for telehealth appointments if parents arrive without the child?
That one's to me.
Oh, without the patient visit, they could use an E&M based on time.
Yeah, so the only way to bill an E&M without the patient legitimately is based on time. And so if you're not allowed to do that, you cannot bill an outpatient E&M if it's appropriate. If you did family therapy and it lasted at least 26 minutes face-to-face, you can use a 90846.
Okay. And this one's specifically for you, Dr. Shane. Dr. Shane mentioned at a prior seminar saying to minimize use of time-based coding because it may elevate your risk for an audit. Do you still provide this guidance with the changes in E&M coding?
So what could elevate your risk is if you use a lot of 99215s, and that was true before, and I believe it's still true. Of course, we don't have data yet from 2021, but I would assume lots of 99215s, whether you bill it based on time or medical decision making, is going to be a red flag.
If the patient is present, you'll be better off billing an E&M code, even if it's a lower level E&M code, and then adding on the psychotherapy to that code, and you will find that your RVUs will be higher if you do it that way than just billing E&M on time. The patient would have to be present for the E&M, at least part of that time.
And Dr. Brand Seabrook, is there a way to bill for school consultations or attending IEP meetings?
Not really. The interprofessional consultation codes, if you speak to the school psychologist or social worker, you might be able to get away billing for that. You do have to submit a report for that to them. If you attend a team conference, yes, there are team conference codes, but all of those people would also have to have the ability to bill, and that probably wouldn't happen. You could say it's you're meeting the patient's needs and perhaps get away with an E&M with the patient there and discussing it with other healthcare providers. But to me, it would be very unclear. I always assumed I would not get paid for that and never billed for it.
Now the other option is if the service is 30 minutes or more on a single date, you can try billing at 99358 359. Keep in mind, reimbursement for those codes is muddy currently. It will not be paid by Medicare, and it's unclear what other payers are doing with it.
Okay. And then Dr. Shane, acknowledging that down coding is technically illegal, do you think it could be a helpful strategy to avoid audits insurance issues? If you see a complex patient twice a week for 60 minutes where the service provided is 99214 plus 90846, but you and the family do not want the drama of insurance likely fighting that, can you code it as 99213 plus 90836?
Yes, try to document it for those codes, however. And but keep in mind, you're dealing with a payer issue. If criteria meet a particular level of code for CPT, then it's legitimate by CPT as long as medical necessity is there. But you may be putting yourself, giving yourself red flags for payers, and so you need to take that into account.
If you're doing the work of the higher level code and you document the code, you can bill it, and then you can do the psychotherapy for however much time you're doing the psychotherapy component. The important thing is to document very carefully and thoroughly what you are doing. So if you do get audited, they can look at your note and they can say, okay, the doctor really did the work, so therefore they can get paid for it.
Okay. And can you code for testifying in court for involuntary commitment?
Again, I think it's back to where on the previous question, there are no real codes for court testimony. So as far as I know, you can't get paid. And when I did it, the person who wanted me to testify paid my bill.
Yeah, so that particular one is certainly for medical care. However, I agree, it's dicey whether it's covered by CPT.
Can you give examples of clinical visits using the interactive complexity code 90785? How often do you use this code?
So 90785 is only for psychiatric codes, specifically the psychotherapy codes and the two psychiatric evaluation codes. 90785 does not apply to E&M codes. And I use almost exclusively E&M codes, and so have rarely used 90785 personally. But if you do a lot of psychotherapy or use 90792 a lot, and you meet criteria for interactive complexity, then certainly go ahead and use it.
For child psychiatrists, I think the most common time you could use it is when you're doing play therapy, what we call play therapy with the kids, where you're using something other than verbal interaction to get information and or offer corrective behavioral change in the child, behavioral emotional change.
Okay. And next question is, I have heard that E&M plus psychotherapy code is reimbursed more highly than a family therapy code. If your visit meets criteria for either code, can you choose? And if so, which one would you choose?
Well, E&Ms would typically pay more than the psychotherapy codes. So you could do the E&M by time. Your choice. There's no right or wrong rule. You just have to document what you're doing to justify your use of that code. If it's family psychotherapy, you want to document what issues you were being addressed during that session and what your recommendations might have been during that session. If it's the E&M, obviously the conditions that you are addressing with the and during the time during your discussion with the parents and or family.
Okay. Next question is there a code for preparation of letters for patients?
So that would also come under a prolonged service code, prolonged service without patient present. If you spent more than 30 minutes, you can certainly do that. You can use an unspecified psychiatric service, not, it's the last one, 90899, I believe, and have your own practice charge for that. But there's no, and I believe there may be, Sherry, do you know, is there a preparation of records that you can use for this?
There's a review of records you can use, not so much preparation. If that letter is written on the day you saw the patient as part of an E&M, you could do it as part of your E&M time. Like say somebody says, I need a school letter to go on a trip or to miss class for something and you don't want to do it at the session because you don't have time, but you can tell the parent, okay, stop by the end of the day or tomorrow and we'll have it ready for you. You just do it that day within that 24-hour period of the time that you calendar day of the day of the visit.
Yeah, I can tell you personally, I have a different strategy for those letters. I don't charge for them. It's more trouble to charge for them than it is probably to write the letter. What I do though is I have patient or parents write a drafted letter. I then look it over. My nurse puts it on stationery, and it usually just takes me the time it takes to read it and sign it.
Yeah, many of those letters are very standard form letters, and you can just have a template. Or you can have something there with the patient's name not in it. You pull it out of your file drawer and you put the patient's name in and you sign it, and that's it. So it takes you, 10 seconds, and it becomes part of your E&M visit. If that puts you in the next level, great. If it doesn't, probably it won't. These are many of the things that we do as child psychiatrists, and a lot of physicians in general do a lot of these administrative functions, which really aren't paid for. They're not considered as part of the time work that the codes include. Part of the big review of the codes, both the new outpatient E&M codes, and then in 2023, when the inpatient and other E&M codes that have been reviewed come into use, they're trying to adjust for this amount of time spent in administrative tasks that physicians do, pre-auths, letters, all of this stuff, filling out forms that are being demanded by the various insurance carriers and or Medicare. So hopefully some of this can be addressed in the time allowances that the newer codes are giving us these days.
Next question is, I may have misunderstood, but is it correct that for add-on individual psychotherapy code, the patient only needs to be present for 50% of the time, such as when seeing child and parents for the child, and the child is only present for part of the session?
Yes, 50% or more, but as long as they're there for 51%, you're good.
I tend to bill 99214 every week for children in residential facilities. Any concerns with this? I am doing active treatment.
Again, it's all in your documentation. If you document the conditions and you meet the criteria for 99214, 2 chronic conditions, or 1 condition and an acute exacerbation, and you document your treatment plan and what your medical decision making is on it, whether you're continuing, changing, stopping, fine.
In a 30-minute follow-up appointment with parents only, but discussion is on the 2 to 3 illnesses and treatment plans, etc., can we bill 99214 instead of 90846?
So yes, you said 30 minutes. So as long as your total time across the calendar day is 30 minutes, it qualifies for 99214. It doesn't matter what the medical decision making is.
For telepsych visit, if the patient is in the same house as the parents, but you never are able to lay eyes on them, does that count as patient present or not present for the visit?
It's saying not present. If you can't see, if you never see the patient. I mean, that would be just like having a patient sit in your waiting room and you only meet with the parents. During the session, the patient wasn't present.
Yeah, I would say that there would need to be some attempt at interaction. So if the patient is hiding under the covers, you try to talk to them. You can see the video of them hiding under the covers. Then that's patient present. If they're simply in another part of the house doing whatever, and the parent's talking to you, then they're not present.
And can you repeat the minimum time necessary for the family therapy codes 90846 or 90847?
So
Yeah, half of
well,
Probably 25 minutes or 26 minutes because it's 50 minutes for 90847.
Right. So these are both 50-minute codes, and so once you cross the midline to 26 minutes, you meet criteria.
Okay. What do you think about billing 90882, environmental intervention for attending IEPs and the like?
You can bill it. The question is, will it get paid? It's, you know, it sort of meets the criteria, but it's typically a code that's not been paid for.
Yeah, typically those last few codes that are in the manual are not paid. There may be payers though with whom you negotiate who will pay you because they want you to do that particular service, but most of the time they don't pay it.
What is the difference between telephone codes 99441 and 99442?
Fine. 99441, I think, would be 5 to 10 minutes, and the other one is, I can't remember exact time frames, but it's a time thing. So
yeah, so two is 11 to 20, 3 is
that what it is? Yeah.
20, 21 and above. Otherwise, there is no difference in criteria.
And how about psychiatric services in an ER? We have been told ER has to be MDM, not time-based. When patients are reevaluated by multiple providers in a day as they change and ER shifts change, can you have multiple codes in a day? When a patient returns to an ER again in a short time frame, can you bill for a new evaluation again, or is the ER considered a team such that it is once every 3 years?
Okay, so part of this depends on if you are the emergency room physician, which, you know, maybe some psychiatrists are, then you must use the emergency room codes, which are totally different from the outpatient codes and have not changed. They will change in 23, but they have not changed so far. And those are not based on time. If you are the psychiatrist called in to see the patient, it depends. So sometimes the emergency room is used as a courtesy. So in other words, the doctor says, well, just come to the emergency room, I'll see you there. It's not really an emergency, but you know, it's after hours. And so then that's strictly an outpatient code. If you are seeing them as a consultation, then you can use the consultation codes or 90792.
Consultation codes are still being paid by some third-party carriers. Medicare is not paying them, but again, this is another code set that's being completely reviewed. We may have different answers for you come 2023.
Next question.
And actually that exact question is clarified in the 23 criteria. And so it's more ambiguous now.
You assume it's going to be clarified.
You always hope. Okay. All right. So next question. As a follow-up regarding new patient codes within the same practice, can you clarify regarding the requirement for the other provider being in the same subspecialty? How does this relate to patients being seen by nurse practitioners? What about colleagues without child and adolescent psychiatry training? What about child and adolescent psychiatrists seeing adult patients? And I can repeat those parts too.
Which codes
Is
was
that my question? Is that one my question or?
I've lost track. It can be your
Okay,
the question. It got a little jumbled to me.
well, actually, maybe just ask. There's like 4 questions there. Maybe just ask them one at a time.
Yeah.
Let's do one at a time. All right. As a follow-up regarding new patient codes within the same practice, can you clarify regarding the requirement for the other provider being in the same subspecialty?
If it's the same practice, then it's the patient's a patient of the practice. So any provider in that practice could not use a new patient code if it's already been used by the initial provider.
Yeah, so I can clarify. So if you're dealing with a child or adolescent and you are a child and adolescent psychiatrist, the patient was seen by an adult psychiatrist, that is not the same subspecialty. However, if you see an adult patient who was seen by a general psychiatrist, then you are in the same subspecialty because you're not using your CNA subspecialty.
Okay, and then the follow-up questions that they were asking was, how does this relate to patients seen by nurse practitioners or colleagues without child and adolescent psychiatry training? And then again, kind of what you just talked about, or about child and adolescent psychiatrists seeing adult patients. So for the nurse practitioners, how would that relate?
If
Okay,
that
so-
nurse practitioner is, I think certified to do child patients and is handling child and adolescent patients in the practice, it would be the same practice situation. If the nurse practitioner, say, is medically trained and is doing some kind of a medical evaluation, part of the psychiatric care, then that would be considered a medical situation, and she could bill it however, whatever fits, whether it's a new patient to her or an established patient by her.
Yeah, so it depends on what the specialty and subspecialty is of the physician with whom the nurse practitioner works. So in most states which require that nurse practitioners are supervised, it's straightforward. It's the supervisor. Some states do not require that, and then it's a bit more ambiguous. But it's generally, what they consider themselves, or the physician whom they're working determines the specialty and subspecialty.
Okay, and then the question about what about a colleague without child and adolescent psychiatry training? So let's say a general psychiatrist saw, let's say, an adolescent, and then they wanted to, then you saw them. Would that
Yeah,
be?
so I answered that one already. So that one,
Yeah.
you are a different subspecialty then.
Okay, perfect. All right. So next question is, if you're doing a telepsych visit and there are technical problems, so you switch to just talking on the phone, would it count as a telehealth or phone visit? And does it matter how early in the visit that happens?
It's my understanding that it does count, but now you don't have to have the visual because a lot of people have problems with internet connections or don't have computers. So it was my understanding that telehealth is allowing phone visits, but again, it's all in the documentation. You need to document it.
Yeah, so some states have provided emergency orders such that audio counts the same as audiovisual in terms of telehealth. Some payers will also pay that. Medicare specifically does not pay for phone calls because they say they have separate phone calls. And so if you're doing audio video and at some point the video poops out and you continue with audio, it really depends on whether you did enough of the audio video to meet E&M criteria, whether you're going to count that as a E&M code for audio visual. So if it happens right at the beginning, then the answer would be no. On the other hand, if it happens later on and you're just doing some, housekeeping things like where should I send the prescription, take this dose, when's the next visit, that kind of thing, then, certainly that would count.
Okay. And next question, any advice on billing for missed sessions? My EHR system bills 90899 for missed sessions, but I'm concerned it is not correct to attach any CPT to a missed session.
Missed sessions are not medical services, so that's correct.
Yeah, I would not bill a code with it. I would bill it as a missed service, but not a CPT code. And with the patient understanding and having signed a financial agreement with you that they agree that they will be billed for missed services.
Sorry, let me jump in. I cut part of the question for brevity, but I think also they were looking for guidance. Is there somewhere you can reference that they could use as proof to argue with their EHR that that's not an appropriate practice? Do you guys know of a reference maybe?
Well, it would have to be a self-pay service. You can certainly use a code to designate it, like 90899, so that you can track it. But but keep in mind, it is not a medical service. It doesn't go to insurance companies.
And if they're concerned about the billing practices, they probably should go down there and tell their billers that they're not going to bill anything other than a missed service. And they can put a computer code in that's not, I wouldn't even use any CPT code. Just have them put in a computer code that designates it as a missed session and, you know, what the fee is.
Yeah, I guess
So
their
you
billers
could-
were looking for proof that it was illegal and that they were refusing to remove it unless the doctor provided them proof. So,
Well, so I don't know that we have proof, but it is not a medical service. But again, what Sherry said, you can make up a code. So, you know, 99999, whatever, but just not a CPT code.
Okay. And next question. If we involve a physician assistant or a medical assistant in the assessment of new patients or in getting vital signs and helping the patient in completing rating scales or suicide risk assessment, can the time be part of the service? What about completing treatment plans?
So the time is your personal time. The only exception is if you are dividing the time with another qualified healthcare professional, so another child psychiatrist, for example, then you could add those times together and bill based on time. But if it's a non-billing provider, no, if you're billing based on time, it is your personal time. It can count toward medical decision making, however, and so you can use those data for MDM.
Non-clinical, or I shouldn't say non-clinical, clinical staff that can't bill as part of what's known as the practice expense of the code. So that's included in the codes. Now, psychiatry codes don't have very much practical expense, clinical expense. E&M codes do, which is why sometimes you're better off billing an E&M for some of these services, particularly if you're using clinical staff to assist you on gathering some of the data.
Next question. An amount and or complexity data to be reviewed and analyzed in the EM table. Who is considered independent historian? Can you consider a parent as an independent historian?
Yes.
Yes.
Cool. All right.
So it's actually a little bit more complicated than that. So there need to be several conditions. So you know, one is if there's different opinions or different data, then they would be considered independent. If there's conflict between them and the primary historian and the patient, then it's independent. If you can't get an adequate history from the patient, then it's independent. And AACAP facilitated getting this language put in. If it's judged as needed for a confirmation, then it's independent. But you need to document that.
Okay. Next question. If RVU isn't an issue, does it matter if one chooses time-based versus MDM code for coding?
It's what you document. You can do either one. I mean, the RVU is the same for the code, whether you use it time-based or medical decision making. So it's what you do and what you document you do that will determine how you would choose that code.
Okay. Next question. Does time-based coding for seeing parents only who also work for an adult patient? Sorry, let me start over. Does time-based coding for seeing patients only also work for an adult patient where you see the parents? Or is it only for a child patient where you see the parents?
No, family counts. So
Yeah.
adult or child, as long as they're family.
Okay. And how do you bill for providing weekly individual psychotherapy for a patient who is not on medication and it's not really being considered?
So unless there's medical thinking going on, that's probably going to be one of the pure psychotherapy codes without E&M.
One of the things you may want to, I mean, some people have built a very low level code just to document that there was medical thinking, and the medical thinking was, you know, treatment is proceeding nicely with psychotherapy. I don't need to change my treatment plan. I don't need medication, the patient doesn't need medication or any other intervention. So it's a very low level decision-making on your E&M, but it's still the additional E&M code that you can use.
So I'm going to need to sign off for 2 or 3 minutes. I'm just going to turn this over to Sherry for briefly.
Okay. And can you comment on T codes, HCPCS codes, such as plus T101016 case management?
With our case management codes, those are, that's a different code set actually than the CPTs. You do have case management codes in the CPT, care management codes, different levels that you can check out in your CPT manual. The care management involves a lot of clinical staff work, not so much physician work, but it's used in the process of transferring patients from inpatient to maybe a day hospital or outpatient care. The other care management codes are more like team meeting kinds of things. The question is how much is going to be paid and how frequent. Certainly in a child outpatient practice, you're not going to come across these codes very frequently when you're using them. You have the transitional care, you have chronic transitional care. There's all kinds of things that were developed more for the Medicaid population and the more chronically ill patients that are there in your CPT manual, but are really a little bit beyond the scope, I think, of what we plan to cover today.
Okay.
Dottie, Jason, any more comments?
No, I mean, they're asking about HCPCS codes, which, I mean, do you want to explain that a little bit? I'm not fully understanding. I don't think we can bill a HCPCS code ourselves, right?
I don't think
Facility
so.
code?
Yeah, I think those are more hospital kinds of codes.
Yeah, so the hospital will be billing that, not the provider, as far as I understand, so.
Yeah.
Okay. Next question. Do you know if Medicaid pays for point of service 11 office compared to point of service 2?
I'm not sure I understand that. I don't bill, I never billed Medicaid, but what they pay to cover my billing costs.
Yeah, I left this in just to kind of help illustrate any Medicaid-based questions, actually, we can't answer because Medicaids are all local. And so it's completely whatever your local Medicaid says, you have to go with, unfortunately. As far as I know, it's all local law.
Yeah, they're all it's state controlled. So you have to know your local, what your local rules are.
If we do a telephone only visit without video, can we bill 99214 plus 90833?
Yeah, and telephone only is kind of in that gray area. There was discussion for a while that Medicare was agreeing to cover those because of the lack of internet and computer access to many patients. Theoretically, you're supposed to have video for a telemedicine visit. The only thing I could say is you could try billing it. If you do the service, you document the service and you document it was audio only. And the worst case scenario is they say we don't cover audio only visits.
Okay. What about your time supervising junior staff, residents, students that can't bill? I understand that their time can't be billed for. What about your time actively discussing the case with them and making decisions about the case in communication with them?
You would have to document the chart to say that you did all of this and document what you did that meets the requirements of the code you're using. But teaching is not considered a reimbursable medical expense.
Dr. O'Keefe, did you have something you wanted to add to that?
Yeah, pretty much similarly. Basically, your bill if you're the attending, you're billing for the service you provided. You're not billing for the service that any trainees provided, and they're not billing. There was a question earlier that said that used the terminology trainees billing under the attending psychiatrist, but the trainees are not actually billing. You are billing. And therefore, you can only count the time that you've personally spent treating the patient, which is why if you're supervising residents, it makes more sense to bill by medical decision-making, because they can tell you, they can spend more time with the patient. And then when they present it to you, they tell you this symptom, that symptom, this problem, this is what we want to do. And when you approve that, then you've done that, then you have that data and you've made those decisions. And it may be only a very brief period of time, because billing by time, you would have to be only counting the time that you were actually providing the service.
Yeah, and
Not-
let me add to
Not
that. So,
teaching residents.
if you bill based on time, you may bill your own personal time, but you may not bill your personal time that is strictly teaching time over and above what's necessary for the care of that particular patient. So whatever time you bill, it has to be, you could be teaching during it, but it needs to be for care for that patient for that day.
And documented and signed by you in the chart. If a student or resident writes something in the chart, you can say, I reviewed this note and I concur with it, but it has to show that you concur with the findings and you document all of that.
And next question, if I see a patient on the inpatient unit for a 5-day admission and then see them in the office a few weeks later for a follow-up appointment, what would be the appropriate code to use for that? Can I use 99203, 99204, or should I use 90792, or are only the follow-up codes appropriate?
So if you're billing based on E&M,
Established
this is an established patient. So they became established because of any service that's rendered. It doesn't have to be an outpatient E&M code. Any service by you or someone in your group in the same subspecialty. If you need to reevaluate them, you can bill a 90792. But if you were the one seeing them inpatient, I fail to see why you would need to reevaluate them. Typically, I use a 99214 in that situation.
Isn't a physician assistant considered a qualified medical professional? They are used to deliver care in primary care and other specialties.
Yes, and they can bill. They're one of the qualified healthcare professional group that can bill. The state laws may vary and whether they're working under the supervision of a physician or not. They are certainly have been lobbying to become independent. I'm not sure how far they've gotten on that yet.
Okay. And it feels like there's some subjectivity involved for coding a 40-minute plus visit relative, for example, relatively straightforward ADHD visit with nervous parents asking many medication questions. I feel like it could be a time-based 99215 or 99213 plus 90833 without supportive psychotherapy. It seems like the 99215 billing is easier to document, but the 99213 plus 90833 has higher RVU billing with typically more documentation requirements. Could you tell us your opinions about these subjective appointment visits?
So in terms of coding accuracy, and never mind RVUs, if you have an ADHD visit with lots of medicine questions, that's all medical. And so, 40 minutes, it's 99215. If, on the other hand, you've mixed some medical with psychotherapy and you've done at least 16 minutes, then you use the psychotherapy add-on.
One of the things you may look at, again, if the component of counseling guidance is much more disruptive because of the parents' anxiety, numerous questioning and re-questioning, and you need to repeat, then you have an issue of the interactive complexity code, which you could add on to the, no, actually you can't add it on to psychotherapy. I'll take that back. You'd have to decide, is it more psychotherapy you're doing or more the medical decision-making and discussion? Dottie had her hand up.
I'd say this hinges on this question of what's counseling and what's therapy. And so if you're going to call it therapy, then you've really got to phrase your note in such a way that makes it clear that you weren't simply talking about potential side effects and how, don't worry, we'll manage them and we'll do this and that, but that you're really addressing parents' ambivalence about treatment or their questions about how it's going to impact their relationships or something like that. So it seems to me it would be it would take more careful documentation to be able to
I
support
agree.
this as psychotherapy. But if you can, but if you have that and you can do it, then, then good luck.
And furthermore, the interactive complexity may not be added onto the E&M code. And so if you're building an E&M plus a psychotherapy code, and one of the criteria is caregiver difficulties, and so if that interferes with the E&M, you're still out of luck. It's not a 90785. But if the caregiver ambivalence interferes or makes it more challenging to provide the psychotherapy, then yes, you build a psychotherapy plus interactive complexity.
Next question. If I'm seeing a known patient in another practice, can I bill as a new patient eval in code 90792?
The patient is new to this practice.
That's what I'm assuming.
If it's new to the practice, yes, you can bill the either a new patient E&M or your psychiatric diagnostic code. Either one would be appropriate.
Well, so I'm going to interpret the question differently. So it sounds, you said known patient. So I assume that you as a provider have seen this patient when you were in a different practice and now you're in a new practice. It's still an established patient. And so whatever the rules are that apply there. So you can't use a new E&M, a new patient E&M code. If it's appropriate and there's a reason to do a reevaluation, you could do a 90792.
I didn't hear that it was known to the practitioner. I didn't hear that part. I'm sorry about that.
All right. Is there an add-on code if you are doing screening questionnaires like PHQA?
You're doing the questionnaire and they have the patients filling out the questionnaire.
Yeah.
That it's not really an add-on code. Could be used part of your data points if you score it and you interpret it during the session, but there's no separate code for it. You have
So there's a group of 96127, for example, may be used for a brief behavioral standardized scale. It's for the administration of the scale, not the interpretation though. The interpretation counts in your E&M.
Yeah, but those are more for emotional, behavioral, like a Connors or a Scared or something like that. Those scales, they're not history scales. They're not.
Yes.
They're for emotional behavioral screening forms is what they are.
And this may be just a follow-up to this. What code would you use for administering a KSADS?
KSADS could be a part of those emotional behavioral screening codes. It's basically a diagnostic interview code.
You can certainly do that, except it's really designated as a brief scale, which I certainly wouldn't call a KSADS. If it's part of your initial visit or you have another reason to do a psychiatric evaluation, you can use a new patient code or 90792. If you are a psychologist, you could probably bill a psychological testing code by the hour. I don't think we can get away with that though.
Next question. What code would be used for QB check test? It is like a continuous performance task for ADHD symptoms.
These are part of the psychological testing codes, computer-based codes. You can try billing them because the code itself doesn't restrict them to psychologists, but frequently various plans and or your ability to get a hold of that equipment. But it's really it's a computer-based psychological test code is what it amounts to.
Yeah, I agree. And it's unlikely that we're going to get paid for a psychological testing code.
Okay. And if you have the parents sign medication consent forms that were sent, does that add to the complexity for your visit?
Well, it depends on the medications. I mean, how many medications, how many conditions are you treating? That adds to it, not the fact that they agreed to the treatment.
Yeah, well, certainly medication management is part of risk criteria. And so, yes, that would add to complexity, but not specifically signing forms. Would be anything you needed to do as far as medication management that day for prescription medication.
You would certainly want to document your records that the parents agreed to this and signed a consent form. But that's not, again, that's based on your own medical management overall, not the specific form that they signed.
What about reviewing medical records from pediatrician? Does that count for case management?
Well, I mean, the pediatrician sends you the records to review it and for your, whether it's an established patient or a new patient, just for your information, or are you doing it as a service to the pediatrician?
So let me answer that. So it would count as part of data. Unfortunately, it would count as one unique record because it's by source. And it's highly unlikely that data is going to change how we code a particular visit. And so, yes, in theory, it adds to the complexity, but it's unlikely that it's going to change any coding levels for us. If it's on a different day and it's 30 minutes or more, and it's not a Medicare patient, then you can use a 99358.
There are situations where I'm documenting 99214 criteria, but then stating criteria met for 99214 plus 90836, but billing 99213 plus 90836 due to insurance tolerance for frequency of treatment. Could that cause problems on chart audit?
Maybe.
Yeah, I mean, part of it is they're billing, they're down coding because the insurance says that that's how often they'll pay for it, even though they're doing something more. Is that the question? Did I understand that correctly?
I can repeat the question. I'm not sure. There are situations where I'm documenting 99214 criteria, but then stating in quotes, criteria met for 99214 plus 90836, but billing 99213 plus 90836, and that's all in quotes, due to insurance tolerance for frequency of treatment. Could that cause problems on chart audit?
Well, you can get penalized for undercoding as well as upcoding. So potentially it could if you're actually doing the work at the higher level code and documenting it. So I would be wary of documenting, reporting a code for something other than what I actually did and documented. I think it's always risky.
Yeah, you're basically I think the nature of this question is that they're basically, you're kind of incriminating yourself by writing that the visit met criteria for 99214, but you billed a 99213. If you just documented a visit and it looks like a 99214, but you billed a 99213, I think you'd actually be less likely to run into problems than explicitly stating that you miscoded it, because then that's technically a violation of law. I mean, you're falsifying your record basically, or your billing. Sorry, your billing.
Okay. For add-on individual psychotherapy codes, is this just pertaining to psychotherapy with a patient directly, or could the time spent be a mixture of psychotherapy with patient and parents?
So yes, as long as the patient is physically present for at least for 50% or more of the time.
And what CPT code would you bill for the ADOS 2? It takes 2 hours. I have been billing as an initial evaluation. Is this okay?
I'm sorry, I didn't get that, Morgan. Can you repeat it?
Absolutely. What CPT code would you bill for the ADOS 2? It takes 2 hours. I have been billing as an initial evaluation. Is this okay?
The ADOF 2 is a structured, I'm not familiar with that instrument.
I'm assuming it's the ADOS like for autism.
It's the
screening.
autism one, okay. If that's part of your evaluation, yeah, that would be, you could bill that as part of your evaluation. But a psychiatric evaluation is untimed, so you're going to get what you get for that code.
Yeah, there's also a group of ABA codes that you may qualify for.
So I think they're doing an actual ADOS and then just the ADOS, which is normally done by psychologists. So I don't know that we actually know, because there's probably a code specifically for the ADOS, or it falls under one of the psychological tests for psychologists. It sounds like they're only doing that on their visit. They're not saying that they did an initial eval plus an ADOS. They just met with the patient for the ADOS. So
I think it's another one of those gray areas for us. It's unclear.
Yeah, there's a whole set of codes for applied behavioral analysis that that this might qualify for. I'm not sure that it pays at psychiatrist rates though.
Okay. And can we use time-based 99213/99214 and add on 90833?
You can't use time-based E&M and a psychotherapy code. If you're using psychotherapy, you have to use medical decision-making for your E&M.
Okay. And that's the questions that I have from the chat so far. We have some other, well, I guess at this point, we have some other questions from before, if we want to go through that, or if anyone else has any other questions they'd like to put in the chat. We have one.
Yeah, I mean, we can go until, you know what, 2 o'clock. It's 27 more minutes.
we got one more from the chat. I just typed it in. If you want to do that one real quick.
Thank you. Is there any generally accepted time spent to achieve certain levels of MDM-based coding?
No.
If you do MDM, you don't have to deal with time. You have to just document what you do to justify the choice of the MDM that you make.
You just have to keep in mind it's not zero time. It's not that it doesn't take time. It's just you don't have to figure out what it is. One mistake is to bill an E&M with a add-on psychotherapy code and figure that the E&M is not time-based, so it doesn't take any time, and you could do the whole thing as psychotherapy. Well, that's incorrect. The E&M does take time. You just don't have to quantify it.
Again, the issue is document what you did for the E&M code, whether you did a small amount or a large amount. And then your psychotherapy code is based on how much time you spent in that time allotted for your session on psychotherapy. You spend 20 minutes on a E&M code because it's a complex medical code, and you scheduled a 45-minute session. You basically only have 25 minutes, so it would be a half an hour psychotherapy session. It would not be a 45-minute psychotherapy session. On the other hand, if you did a complex 99214 code and you could do it in 10 minutes or 15 minutes, and you wanted to bill a 45-minute session because 45 minutes on the whole code, you could probably get away with that. As long as you just have to document what you do.
And another question from previously, since there are no longer required bullets, do we have to document constitutional signs, symptoms, vital signs, a complete mental status exam, etc. on every note? Does it differ if we are coding based on time versus MDM?
So you need to document a clinically appropriate physical. And so whatever is clinically appropriate for that patient for that day must be documented. But there are no bullets that are counted, and you don't need specific areas that are not necessarily relevant.
And if, vital signs, blood pulse, blood pressure, height or weight are indicated for your medical, your medical part, yes, you should put those in to show that you are managing those things that could be side effects of the medication, but they're not required if there's no indication to monitor them.
Another question from the chat. I have clients that prefer 90-minute to up to 3-hour appointments. Any recommendations on appropriate billing, assuming it was a shorter appointment? Assuming if it was a shorter appointment, it would be at a 99214 level.
So a couple of choices. You can do an E&M with additional psychotherapy add-ons that only goes as high as 60 minutes. I mean, that's 90838 is going to be the longest add-on. Or if that entire time was a medical service, then you can use the old office visit add-ons. So 9935455, which can go unlimited as long as it's medically necessary. That's true for now. Starting in 23, that will go away though. But for now, that's allowed. There needs to be, you need to be documenting that you need all that time for medical purposes though, and why you're doing 90-minute or 3-hour sessions. It's hard to imagine payers paying for that.
What should I do about vital signs in a telepsych visit? Can we have the patient do their own vital signs for the visit?
Yes.
They could show you if they're using one of the digital readouts, they could do it and you could see it right there. So, but if it's recorded, like if somebody else does it in your office and gives you the value and you record that, then you address vital signs. So yes.
And can you code for doing an AIMS test?
That's again, that's one of like the behavioral emotional screening forms, and you could code that as part of it.
I think AIMS is the involuntary movement scale, and I believe that just falls. So it's the abnormal involuntary movement scale.
Yeah,
I think that's really just part of your mental status for most people.
Right. So that would just be considered physical examination that you need to do when appropriate.
If you were doing time-based follow-up with parent, patient not present, 99213-5, other than documenting who was present, do you need to write something additional for the mental status exam?
No, because you don't need to do one.
Well, there is no mental status when you don't have a patient there. You do need to, whenever you do time-based coding though, you need to document what the activities are that made up that time. And so that needs to be, those activities need to be exactly what Dottie listed as the list of activities that are allowed. And so it's good to have an EHR that will spit these out automatically rather than you having to, longhand write out exactly what you did.
If you, oh, sorry, can you clarify why we can't bill time-based EM with add-on therapy codes for a 40-minute visit? Can we separate saying 20 minutes E&M and 20-minute add-on therapy?
It's specifically disallowed in the CPT manual. That's been true since 2013 and it remains true.
Okay. All right, so those are the questions from the chat. Some of the other questions that I can go through from before. Let me try to see if any of these haven't already been answered. The initial child and adolescent psychiatry evaluation often takes more than one 60-minute appointment, as you often have to obtain collateral history from multiple sources? Am I allowed to bill for 2 separate visits with 99204 or 99025?
No,
So you
for
may
one,
not
and-
use a 992 or 4 or 5 when there's any previous service. However, you may repeat a 90792 for additional informants. So if you have one session where you're primarily getting history from the patient and another session where you're primarily getting history from parents, then you can use 90792 twice.
Or you could use a 99215 based on time if you're just doing, say, you need an interview with a parent or a child or something for 45 minutes, 45 to 50 minutes based on time.
And what is the appropriate add-on CPT code to be used for extended psychotherapy sessions? For example, how should a 90-minute session be coded? Would it be 90837 plus ?
Yeah, so it'd be 90837 plus a 99354, as long as it's 90 minutes or more. And if you continue adding more time in, you can add in a 99355. That goes away in 23, but we can do that currently.
Okay. And I think most of the other questions we have already been answered. So that might be about it from the questions that I have.
Got 2 more that just came in. I haven't been able to screen them yet. Do you just want to read them off the chat?
Yep, got it. Our EMR macro still has the counseling documentation support more than 50% time spent on counseling. Is this relevant anymore?
No, not relevant.
No.
Okay. When do you choose 90791 compared to 99205?
Well, 90, what is that? What, you're talking about the psychiatric diagnostic code. Is that one? Is that the code? What was
I
it?
think it's
So they're wondering about
92.
90792 versus 99204.
Okay, 92. Okay, yeah, 91 is without medical, 92 is with medical. You could use either one, depending what you're doing. Sometimes it's good to use if you're seeing the parent and the child together on their first visit, you can use the E&M code. Otherwise, if the child is not there in the first visit, you would have to use the diagnostic code, but then you couldn't use the new patient code when you saw the child because it's already an established patient. So it depends on how you do your evaluations.
Yeah. I mean, part of it depends on whether it's more medically oriented versus psychiatrically oriented, which whether you use the medical or the psychiatric code. But if the patient hasn't been seen in the last 3 years by you or someone else in your practice, same subspecialty, you can certainly use a 99205 if you meet other criteria. If it's just the parents, you can use a 99205 based on time, but not based on medical decision making.
And
Do more in the document again.
yes,
Morgan.
thank you. I appreciate it. Can you do a 99215 one session and then a following session if one interview is with parent and the other with a child for new evaluation?
I think they mean 99205.
Okay, cool. That's what I was like. Can you do a 99205 one session and then a following session if one interview is with parent and the other with a child?
Yes, but not the
Yeah.
reverse.
You're asking about billing 99205 twice. Sorry.
Oh no, I'm sorry. I misunderstood. No, you can't bill it
Yeah.
twice.
You can do the 99205 for the initial visit, and then you could do your 90792 code for the subsequent visit. Once, maybe twice, you could get away with it.
And again, we're not speaking to whether your insurance is going to choose to pay that or not. We're just talking about what's allowed in CPT rules.
Correct, yeah.
That's an important
Good point, Jason. Yeah.
clarification.
Can you code 99214 and 90833 without child present, it is parents only.
No, because to do a 90833, the E&M needs to be based on medical decision-making, which you may not do if the child is not present.
Can we code 99214 with 99354 for prolonged visits?
Now you go up to the next higher level based on time, and then you could start your prolonged visit.
So actually that is ambiguous. So according to CPT, you may, insurance may kick that out. But let's say medical decision making is at the 99214 level. It doesn't meet 1.5 criteria, but based on time, you spent 60 minutes. So that'd be 30 minutes for the 1.4 plus another. Okay, I'm going to revise what I just said. That answer was prior to 21. So starting at 21, there is no 99354 to add on to E&M. You have to use 99417, which is probably not getting paid nowadays.
Okay. Does documentation count as time or just face-to-face time?
Documentation is part of time. It's a time
So
you use to deliver the service.
right. So starting in 21, time is total time across the calendar day, includes all services you did for that patient, not just face-to-face time.
Every code, when it's valued, accounts for a small amount of time prior to seeing the patient and a slightly larger amount of time after you see the patient, which is for documentations and or follow-ups. It's maybe 7 to 10 minutes afterwards and about 3 to 5 minutes beforehand, which is counted is in the overall value of the code. So if you go beyond that, then you could start using, say, EMM on time that you use throughout that 24-hour count.
Well, that's how it used to be with face-to-face time. The codes are valued based on intra-service as well as pre-service and post-service. So with the new coding, pre-service is before the 24-hour starts, like the day before or 2 days before. Post-service is the next day or the next week. And so those go into the valuation. But in terms of intra-service, what you do that day, all activities go into counting toward time, as long as it's done in that calendar day.
Okay. Was Beverly Hills 90210 a good show? Thank you for that question.
Yeah. So there's actually a separate part of the CPT manual for zip codes.
Love it. All right, so I think that concludes our questions.
Thank you all for attending. If you have other further questions that come up after you think about all this material, contact Karen and she will either answer them for you or get one of us to answer them for you.
So thank you all for coming. We hope we helped.